welcome to the Introductory Ultrasonography course, Vascular Access. Learning objectives: to comprehend the fundamentals of ultrasound dynamics, to demonstrate successful theoretical and clinical manipulation regarding vascular access, to be able to analyze and interpret various vascular access risks and benefits, to introduce and integrate ultrasound theoretical frameworks with a clinical didactic. So what do we know of sound? Sound is measured in hertz, from low pitch to high pitch, and this is the frequency in which ultrasonography works. Where is ultrasonography used, and what is it best utilized for? Primary care general practice and primary care settings have started to apply the use of ultrasonography in the healthcare setting. There's different types of ways ultrasound can help assess, diagnose, and provide implementation pathways for your patients. In a recent study, when they compared nurses-led ultrasound comprehension compared to that of the physician resident, there was a sensitivity of 96.4% and a specificity of 98% when comparing CT-enhanced ultrasonography compared to that of the nurse's assessment via ultrasound. Majority of these patients were in traumatic incidents, and this study was pulled out of Australia. Another study analyzed 392 patients with liver and spleen injuries and demonstrated no significant difference between bleeding between contrast ultrasonography and non-contrast CT. This shows that ultrasonography provides an appropriate assessment and diagnostic tool for your patients regarding abdominal injuries. There has been a long history of ultrasonography used throughout the years. First, it was used by gaining the megahertz through bats, which forms sound, which was gathered through the pheocrystal in the ultrasound, which then transferred through the transducer, which emits certain rays, which is able to give you the reflection of what you see through the ultrasound. Going forward, ultrasound was then developed and used in healthcare settings, used to detecting brain tumors, and then developed using the developmental tools to assess gall. The history of ultrasound continues to analyze of how it was used best in medicine and in healthcare. The ultrasound became a huge popular tool in GYN obstetric medicine in 1958. Then it further continued into becoming a huge and important tool in assessing pneumonia. In 1989, Professor Daniel Lichtenstein began interpreting ultrasonography with lung slides. So what he noticed was that throughout his ultrasound field, he noticed something known as currently B and currently A waves. Daniel Lichtenstein then analyzed that if a patient has these certain type of waves, they have increased fluid and opacity in their lung field. This signified that this patient had pneumonia. So when compared to using chest x-rays as the traditional pneumonia assessment in the ICU, ultrasound showed to be significant because Professor Daniel Lichtenstein was able to then treat his patient successfully using ultrasonography diagnostic tool with pneumonia compared to that of chest x-rays. The basics of ultrasound physics. Frequency refers to the number of cycles of comprehension and refraction in a sound wave per second, with one cycle per second being 1 hertz. This shows an example of how the wavelength transmits and provides certain amplitude which is able to be used in ultrasound. Basic physics of ultrasound continued. Wavelength, the distance by sound in which a cycle or distance between two identical points in the wave cycle, the distance from point to point. So, what we're basically saying here is that the proportion of the frequency and the wavelength is a major factor affecting the axial resolution of an ultrasound image. So, when you have the amplitude and the wavelength, you have a certain propagational velocity, which is the sound that it's able to implement and go and kind of transduce a sound in the appropriate wavelength, which is able to penetrate the resolution field. The smaller the wavelength, and therefore the higher the frequency, the higher the resolution. But less penetration, therefore the higher frequency probes, 5 to 10 millihertz, provide better resolution but can be applied for only superficial structures and in children. Lower frequency probes, 2 to 5 megahertz, provide better penetration through lower resolution. They can be reused to deeper imaging structures. The basics of ultrasound continued. Propagational velocity, the speed at which sound travels through a particular medium and is dependent on the compressibility and the density of the medium. Usually, the more dense the tissue, the faster the propagational velocity. The average velocity of sound in soft tissue such as the chest wall and heart is 1,540 meters per second. Transducer. Inside the core of the transducer are a number of pheocrystals that have the ability to vibrate and produce sound of a particular frequency. When electricity is passed through them, this is how the ultrasound waves are formed. Orientation. There is usually a dot, groove, or light on one ends of the transducer to assist with orientation. Also the medical arrow guidelines as a landmark for appropriate access. So if you see the arrow at the end of your transducer, that is supposed to give you the medial image of where you're supposed to go and get the center view for that appropriate image that you're looking for. For example, in vascular access, if you bring the transducer with the arrow in the middle of the screen, you will then be able to insert the needle directly into the arrow and directly into the vessel which you're trying to cannulate. Ultrasound waves are disrupted by gas or air. It is not to be used primarily for bowel assessment. CT scanning and radiology are appropriate diagnostic measures in this case. Large patients have limitations due to more dense tissue. So if you have a patient who's obese, it's going to be difficult to obtain a good quality image because that dense tissue produces poor quality because it attenuates the sound waves. However, ultrasound waves do not penetrate solid objects such as bone. So if a patient comes in with a fracture, you'd want to get an X-ray. That is the gold standard. However, ultrasound frequency heightens in a higher fluid medium, which is why when a female comes in for a GYN visit, they're told to increase their fluid intake prior to the ultrasound, which then heightens the resolution. Fetal ultrasounds require full patient bladder for appropriate evaluation. Probe handling. How to handle your probe. If you see the picture where it says correct in green, the provider is holding the ultrasound probe sort of like a pen, but with a relaxed arm. The relaxed arm allows the provider to move up and down however they want. You want to have a good grip, and you don't want to hold it down very abrasively, because compressing your structure too much will disrupt the image quality. Ultrasound probe types. Convex probe, linear probe, phased array probe. For the purpose of this talk, we're going to be focusing on the linear probe and the phased array probe. The linear probe gives you the ability to see superficial structures such as that we use in vascular access. The phased array probe gives you the ability to look at deeper structures such as the cardiac window. It allows you to look at all the ventricles, and this type of probe, for example, is used in an echocardiogram. The ultrasound unit. Before modern point-of-care testing, portable ultrasound units were developed. If you see here, it's a large and very cumbersome device. Nowadays, we have handheld pocket-sized devices. Also, the surface area for this device can harbor large amounts of bacteria, and it's very cumbersome to bring into patients' rooms. Ultrasound basics. A convex probe, cardiac abdominal probe, uses a low frequency, thus allowing for deeper tissue penetration, suboptimal resolution compared to a linear probe. A linear probe, vascular probe, uses higher frequency range, allowing for higher image resolution. Ultrasound handling. 3 basic motions: sliding, rocking, fanning. Ultrasound, remember, is used in waves and frequency based on the size and the location of its transducer. If you slide it back and forth, you'll get a better quality resolution. If you rock it, you're able to get a good image quality when you have control. If you rotate it, you're able to get a better access position of where and what you're looking at. Tilting and compressing also are important tips regarding vascular access. If you tilt a probe, it is able to highlight the resolution field of what you're looking for. If you compress a probe, you're able to assess for structures such as arterial versus venous blood flow. Remember, ultrasound is made up of waves. Think of the ocean. When a wave hits the shore, they scatter, and you want to avoid that scattering. Visual specifications. When viewing structures, fluid is black and tissue is gray. The more dense the tissue is, the brighter it will appear. Ultrasound waves will not penetrate bone. Echogenicity describes how ultrasound waves are reflected back to the transducer. Hypercoetic is more transmission. Hypocoetic is less transmission. If you look here on the bottom right, you're able to see the color of bone, tissue, and fluid. So for a vessel, such as a vein, your fluid level will be black. A nerve fiber will be a tissue that will show up gray in between. Long axis view versus short axis view. Short axis view allows you to see the vessel as a circle because it's a cross-sectional view, sort of that of what a CT scan does. A longitudinal view allows you to see the vessel from a parallel side. You're looking directly at the vessel, looking down. So if you look at the bottom right screen, you're able to see the needle that gets cannulated directly into the vessel using a longitudinal view. On the left-hand side, you're able to see your artery versus vein using a short axis view. Vein compressibility. This is an example of your basilic vein, and the basilic vein gets compressed and it disappears. Normal venous flow. These are some tips how to distinguish the normal venous flow compared to that of the arterial flow. For example, if your patient has a large structure such as the IJ up in the neck, you're going to have your patient take a deep breath, strain while holding their breath, and this will provide a Valsalva technique. This will provide great compressibility to distinguish between arterial flow versus venous flow. Compressibility is another option, and there are several more as you see on this slide. The vessel anatomy. The cephalic vein, the brachial vein, and the basilic vein are the three deeper veins usually noticed and seen on the patient's arm. Your gold standard vein for inserting a catheter, such as a PICC line, peripherally inserted central catheter, will be the basilic vein. The cephalic vein is very difficult to see in some patients. It's not always predominant. The brachial vein is very close to your arterial structure, so that's your second to go-to structure when you want to have venous cannulation. You want to avoid the artery at all costs because you could develop things like a pseudoaneurysm if you accidentally nick the artery while trying to access the venous structure. That's why the basilic vein is the gold standard, because it's far away from the brachial vein and artery. If you see here on the right, you're able to see the basilic vein, which is large and furthest away from the artery. Vessel selection. Like I said, you want to go into the basilic vein because that's your gold standard. If you look here and these little gray outlines on the right side, you're able to see the nerve fibers. These nerve fibers will cause extreme amount of pain to the patient during vascular access cannulation. You want to avoid these structures. If they're unavoidable, you want to administer as much lidocaine as you can to provide your patient the most amount of comfort. Modifying Salinger technique. This is a technique used to develop for central line access. You introduce the needle to the vein. Once your needle is in the vein, you will see a little bit of blood pour back. The blood will pour back as it drips out the needle, which has an open end port. Once the needle is dripping the blood, you then take a guide wire and you thread the guide wire through the needle all the way through. You never let go of your guide wire, you always keep it in your other hand, and then you take the needle out, which rides over the guide wire. So once the needle is out, all you have left is the guide wire that's in. Then you take your dilator or microsheath and thread it through the guide wire. It goes into the skin and the guide wire stays out. Then you take your guide wire out and the microsheath or dilator is left in the vessel. Then you thread your catheter through and you crack open your dilator or microsheath. As you're cracking it open, you pull the catheter in further and further, and this will provide successful cannulation via modified Salinger technique. You'll be able to practice this more. What happens to the ultrasound waves once they enter the body? Only some of the waves return back to the probe to help the machine form an image. The rest are lost. When ultrasound waves enter the body, the waves undergo the following process: attenuation, refraction, reflection. Attenuation is when the body absorbs some of the ultrasound energy, making the waves appear. The waves don't return to the probe and are therefore wasted. The more of the body tissues that the ultrasound waves have to cross, the more attenuation the waves suffer. That is the only reason why it is more difficult to image deeper structures in obese population patients. Attenuation is the measure at the reach of which the intensity of the ultrasound beam diminishes as it penetrates the tissues. Attenuation always increases with depth. The higher the frequency of the ultrasound, the more rapidly it will attenuate. Refraction. Every substance, nerves, muscles, or fat has a unique property called acoustic impedance. Acoustic impedance is a somewhat complicated concept, but basically depends on the density of the substance and the speed of that substance. Substances with different acoustic impedances alter the course of ultrasound waves in an important manner. Refraction. When the ultrasound waves tries to pass from one substance to another, substances with a different acoustic impedance part of the ultrasound waves continues into the second substance, but becomes slightly bent away from the original direction. The bending away when the ultrasound passes from one substance to another substance with a different acoustic impedance is called reflection. Irregular surface objects such as nerves scatter to the ultrasound waves in all directions. A small portion of the waves are reflected back to the probe. This is called scattered reflection. If an object is large and smooth like a needle, the ultrasound wave is reflected back. This is something that you want to see when you're providing vascular access with needle cannulation. The reason why you want to see this is because it's going to give you a view of where your needle is in regards to your vessel. This is very useful since it helps you to see clearly where the needle is. It's a mirror image like reflection. The waves will reflect back at you and you're able to see that. This is a picture describing the different reflection types: attenuation, absorption, reflection, scattering, refraction, diffraction. Scattering, reflection, and absorption are some of the common ones. Refraction will become more common if there's a structure in between your imaging that you're trying to obtain. Attenuation is standard, and it's the waves absorbing the structure. Diffraction is a little bit more complicated because it's waves that grow larger and larger in size as they penetrate through. However, this is also a vital assessment tool into understanding the ultrasonography physiology. Specular reflection. If you see here, you're able to see the needle directly entering the vein. This is both a long axis view and short axis view. You'll be able to practice this more with the phantoms. What do we avoid? The nerve fibers. You want to avoid those nerve fibers because this is going to be neuropathy-like symptoms that your patient will explain. They're going to say that they're in a lot of pain, it feels like it's burning, electric sharping shooting up my arm. They will not be able to tolerate the procedure. So try to avoid these structures if possible. If not, try to administer as much lidocaine as you can that's appropriate to dosing. Artery versus vein. How do we know? How do we know the artery versus vein? If you look at the bottom right structure, you're able to see your vein compressed and your artery stays circular and pulsatile on the bottom right after compressibility, which is why compressibility is an important tool to be utilized in vascular access. Deep vein thrombosis, DVT. You want to make sure when you're looking at an ultrasound that you're also able to scan the arm up and down the vessel you're selecting. If you see this gray opacity, if you notice with the yellow arrow, that's a clot in a vein. You want to avoid that vein at all costs, even if it's not a diagnostic represented DVT. You want to advocate for your patient to get a duplex or an ultrasound to evaluate DVT. If it's clear and safe to go, then you can appropriately cannulate that vessel. If not, you've then helped diagnose the patient who has a DVT. Various DVT and emboli. If you see your patient has a possible DVT or emboli, avoid cannulating that vessel. It can lead to catastrophic damage, such as the patient could develop a pulmonary embolism when you thread the catheter through, which lodges in the pulmonary vein. This is a risky business. This is an example of a patient who had a PICC line in an artery and it developed a large pseudoaneurysm which led to a hematoma. Yes, things can go haywire. This is an example of various post-chest x-ray confirmation PICC line placements. They're not always going to be where you want them to be, and make sure that you have a radiologist interpret your x-rays if you're using this type of confirmation technology. This is an example of the appropriate landmark of where a PICC line needs to be. If you look at the bottom right, the tip of the PICC line is in the cavo-atrial junction. That is the middle location between the inferior vena cava and the atrium. This is the appropriate landmark of where a PICC line should line. If you look on the upper x-ray, this gives you anatomic landmarks of where your PICC lines can possibly go or wind up. Thank you. This concludes our presentation for the introductory course to vascular access. I want to extend appreciation to Dr. Ahern, Dr. Tucker, and Dr. Sharovsky, and as well as to the Siller Foundation that helped provide the grant funding for this course. If you have any questions, please feel free to ask.